Hey folks, Scott Weingart here, and this is the EMCrit podcast. Today on the podcast, we're going to go over the ACLS guidelines from 2025. And I'm joined again by my buddy, Shel Cheskes, and he is going to discuss the DSED guidelines in the 2025 ACLS guidelines, and we're going to talk about some of the other interesting guidelines as well. Now, what sparked me to get Shel on the show is the ILCOR guidelines. Their wording for DSED was fine, said you may use it, while the AHA guidelines, as you'll hear when we talk about it, they chose different language. I don't know what to do with this. We will discuss shortly. I also was going to mention the mechanical CPR portion of the guidelines, but I decided to just break that off into a separate we because I actually got a guest from ILCOR and the AHA to talk about them with me. So that's coming. Very quick before we dive in, I'm just going to mention the dizziness and vertigo course I did with Peter Johns. It is one of the best things I've done in recent history. It is a fantastic course. It will take you from hating dizziness to all of a sudden being eager to pick these patients up because you just want to try your newfound skills. If that sounds interesting, if all of a sudden being completely comfortable with vertigo would be a positive change in your practice, then go to vertigocourse.com. That address again, vertigocourse.com. And now let's get right in with Sheldon Cheskes on the AHA and ILCOR 2025 guidelines for resuscitation, some of the interesting parts from that. All right, Shel, welcome back. People should know who you are from the previous episodes, but just in case this is their first time tuning in, just give us a brief bio of who you are and what you do.
Yeah, for sure, Scott. It's always great to be here. Yeah, Sheldon Cheskes. I'm a professor of emergency medicine here at University of Toronto, scientist at Li Ka-shing Knowledge Institute at St. Michael's Hospital, and a medical director at Sunnybrook Center for Pre-Hospital Medicine. I think here, though, I generally talk to fibrillation, so I'm the provincial investigator for the dose VF trial. And certainly now it seems once the guidelines came out, I seem to be getting more requests to speak, even though they were a crazy amount before. But now it even seems greater as people are trying to wrap their heads around the guidelines and the science. Thanks for having me. It's always great to be here and looking forward to chatting.
I love it. All right. So obviously the context which has generated this conversation is the fact that the 2025 American Heart Association guidelines have come out for ACLS. The ILCOR guidelines came out simultaneously. All right. Now, the one that got your hackles rising was and we were hoping that things would be different, but the most recent vector change and DSED guidelines, and I'm going to read it verbatim here, the usefulness of double sequential defibrillation for adults in cardiac arrest with persistent VF or pulseless VT after greater than or equal to 3 consecutive shocks has not been established. Tell us your feelings about that, Shel. I'm sure you'd only have minor feelings about that.
Yeah, it's so funny. My wife told me to stay professional, stay calm.
No, that's not what we, I never would say ignore one's wife, but we give you free reign here. The rant is more enjoyable.
My free reign comment would be, I think the recommendation is incorrect, obviously.
All right. Maybe we could put a beer in you and get even a more vitriolic rant, but that's okay.
I think the recommendation is incorrect mainly because it's an interpretation by the people at the HA that also sat on ILCOR. And ILCOR's recommendation was the may be considered recommendation that really opened the door for DSED to be used. I think what people understand is when HA makes a recommendation, there's basically a class of recommendation and a level of evidence. And the class of recommendation for DSED was 2B. So 2B is basically maybe reasonable to use, may be considered, or efficacy has not been proven. So it's very interesting that similar groups in ILCOR said may be considered, whereas AHA used the sort of the lowest echelon of what they could have to keep something within 2B. From the level of evidence, this is moderate quality evidence from randomized controlled trial, so certainly dose VF fit in there. It's interesting how the wording can really change the way people perceive the recommendation. May be considered is something that I think is likely appropriate, if not 2A. And we argued about the grade recommendation at ILCOR that was given to DSED, but I think the use of effectiveness has not yet been established, I think has really changed the way people viewed it. And I think the issue is most people look at that recommendation What they don't look at is actually the interpretation that gave it that recommendation. And when you actually look at the fine point within the chapter, much of this came from an AHA sort of think tank that was put together about a year after Dose VF came out. And so many of these comments were stated there. We basically addressed all of them, and I think their interpretation is incorrect. The trouble is, the run-of-the-mill clinician is not going to read the fine points. They're just going to look at the recommendation and say this was what it is. But if you look at the fine points, here's what they are. Here's what they argued. They argued that the intention to treat analysis was in favor of DSCD, but the treatment received was not. So if you looked at the supplemental guide, treatment received was not positive for DSCD. And it's very common reason. No one looks at treatment received in a randomized controlled trial. A randomized controlled trial, you do it to balance all the potential confounders. When you look at treatment received, you remove randomization. You've turned a randomized trial into an observational study. When you do that, and if you look at the data, the standard arm then had shorter bystander witness, shorter bystander CPR, everything that would favor it. That's why it wasn't positive. But that's not what people report in a randomized controlled trial. It's ITT that people look at.
I want to emphasize that point, Shel.
Yeah,
because
it's huge.
Normally, when you look at an RCT and the intention to treat is negative, then it's sometimes futile to go and look at the actual treatment received and say, all right, I understand our primary outcome didn't hit, but this is still interesting data. Maybe this will be fuel for a next study. I've never heard of anyone looking at a positive intention to treat and then saying, oh, let's go look at the treatment received after that.
It's so funny. We're laughing because you have to understand our methodologists, when they read this, they go crazy. They think this is the craziest thing they've ever seen, that someone focused on a treatment received analysis. And the reason is most treatment received benefit the intervention.
Yes.
But it's random because you've removed randomization. So it really is quite laughable, but that's part of the reasoning for the analysis. They talked also about refractory versus recurrent, and the fact that in our analysis, our secondary analysis, about 83% of the patients were recurrent VF. And in that, even in that, we showed a 10% absolute benefit in neurologically intact survival and survival to hospital discharge. It wasn't statistically significant, but it was clearly clinically relevant. And especially in a small sample size, that's purely a sample size issue. That's not a clinically relevant issue, but they put that in there. And then the final piece, they talk about you need specific timing to do DSCD because that's what the animal study shows. That's a complete misinterpretation of our study that we published that showed in Dose VF, the timing between the two shocks was 650 milliseconds. That's not 10 milliseconds that they're alluding to in the animal studies. And look at the results that we got. We also showed that if you decrease that time, your ROS rates could even be better. But that was like 100 milliseconds. That's not, they're alluding to the fact that they think you have to replicate animal studies to show a benefit. That's completely incorrect. Do you know what I mean? So I think all those three things that they put in the interpretation, we had addressed those in the past, yet they still showed up in this particular guideline.
It's incredibly frustrating. And we've made these points in the prior podcasts you've been here, but it's worth mentioning again. In the study, people were leaving a second between the defibrillations, but you didn't have to do that. And in fact, results would be better if you didn't. So, and doing it with the second between, which would replicate Dose VF, is not hard at all. But doing it like as close to possible is even easier. So it's just crazy making. Would you have been satisfied if they used the same language as ILCOR and simply 100%. Left it as made? Yeah,
100%. Yeah. And that's the frustrating thing. It is pretty rare to see two groups, AHA-ERC, contradict an ILCOR guideline. That's really unusual, especially, as I said, with similar people being on all three areas. The trouble with what they've said is that people who do DSCD now are going to still do DSCD, I guarantee.
Yep.
The people who are on the fence, those are the people that this tends to impact. Do you know what I mean?
Yeah.
So the guideline, it gives you an out if you don't want to go through the process of developing the logistics to do DSCD in whatever your environment you're in, your pre-hospital, ED, ICU, CCU, right? It's easy to say it's not in the guidelines, so I'm not going to do it. So I think those are the people that get affected by this type of guideline recommendation.
I want to go a step further and talk about the really problematical aspect of this is different than giving like a neuroprotective drug where you will never see the results in real time and be able to alter your care. You really need large scale randomized controlled trials to appreciate the utility of that. But what we're really saying here is you have a patient who has been shocked 3 times at maximal energy and they have not converted to a ROSC situation. At that point, everything we do is off guideline. In my mind, as a resuscitation doctor, that's a patient in electrical storm. And I'm going to do all sorts of non-guideline supported things. I'm going to mix antidysrhythmics. I'm going to be considering esmolol, stellate ganglion block, all sorts of things that completely diverge from the guidelines. And we have something that has an RCT behind it that there's no evidence of harm. There's zero evidence of harm from this modality, and you could actually see results in real time. If you had a patient you shocked 3 times at standard, and then the 4th time you did dual sequential, and they shock out, something actually happened there. So, tell me, Shel, because that's what's really frustrating me.
And Scotty, I got to tell you, that was one of the biggest benefits for paramedics in this study. This was not a study that said, let's give a little epi, let's give a little bit more ammo. This is a study where the paramedics saw the immediate results of their intervention.
Yeah.
They saw ROSC and they said, wow, we never saw that before in that type of scenario. That spread like wildfire through the service and actually improved the rates of compliance because they saw, hey, this is going to work. This makes a difference for people. That really helps. So I totally agree with you in terms of how we treat this. And I think what's even more interesting is the Swedes' presentation at ERC at late breaking of their feasibility trial, where they were looking at DSCD after 1 failed shock. So 1 failed EMS shock, and that really goes in keeping with our secondary publications on time and VF. Hey, if time and VF is important, doing it earlier should make it important. So they presented their study, 40 patients, 3-to-1 randomization, DSCD to standard. 80% of patients got DSCD after the 2nd shock. Survival in the DSCD arm, 41%, 9% survival. So again, just this huge benefit that we're seeing. So that's not a signal, that's a monstrous signal. So now when they're moving from their feasibility to the definitive trial, I think this is going to change the world of defibrillation because people are going to realize that to be successful in resuscitation, you need to do things early. And so why wait for 3 shocks if you have an intervention that can be of benefit? So I think the Swede study, I think, is going to make a huge difference in terms of how people look at this modality as well.
Anything else you want to say on dual sequential before we move on?
Yeah. To me, you know what? I think we need to get out of the mindset that vector change and dual sequential are the same. There seems to be this underlying thought process that they're the same. And vector change, for some insane reason, was suggested over DSCD in the ERC guidelines. And let me tell you this, any data on vector change came from the dose VF trial. In the trial, all the point estimates favored DSCD. Every sensitivity analysis favored DSCD. When you see an intervention that improves survival, but not ROSC, it's very unlikely it's related to that intervention. There's confounding that you have missed somewhere, and that's why the fragility index was only 1 for vector change, because the result was very fragile, and who's to know whether that was a true result? Neurointact survival was only improved in the DSCD arm, and the rate of rearrest was highest in the vector change arm. It doesn't make any sense that vector change would ever be done before DSCD. In fact, in our EMS system right now, we don't even do vector change. We begin with pads in the AP position, we defibrillate until a second defibrillator is there, and then we move to DSCD. We would never vector change from AP to AL because we know AP is in fact the better vector.
We got a specific question about this, so I'm so glad you brought that up.
Yeah.
And this will bring us to the next topic too. So in mechanical CPR, which I'm a big fan of, there was the question of whether at that crucial initial portion of the code, the putting on of mechanical CPR actually lost shock opportunities that would have been a potential huge benefit to those patients. And the problem with mechanical CPR might very well have been that it detracted from that initial shock. If you start CPR and go immediately to anterolateral for that first shock, you're going to be able to get rhythm analysis and shock them much more quickly than potentially putting the back pad on. And I don't know where I stand on this. This was a listener question. So they're suggesting maybe we should start with anterolateral pad position, see if we could get that first shock in for a shockable rhythm, and then at some point in the code, sit the patient up for the posterior pad. And now you're ready to vector change and dual sequential, because now you have all 4 pads already on. What's your stance on that, Shel? Obviously, you went a different direction.
Yeah. So I've been through this. My stance on this is the following. The easiest way to do this is I put on the AP pad right from the start. Now you've got AP right away. After 3 failed shocks, we add the AL pads and we're ready to do DSED. The issue about AL versus AP first, we've always felt that AL would be better because it's quicker. You don't have to take off clothes, rod roll, etc. There's a difference between speed and efficacy. Faster by 4 seconds or 5 seconds doesn't mean a more effective shock. We're going to present data from DoseVF very shortly, this article, that shows that the current through the AP pad is significantly greater than the current through the AL pad. And in fact, what we're going to show is that for the same level of current, you can get a 3 times greater rate of ROSC than the AL pad. So we always thought IO was better than IV until you look at a randomized trial, you don't find it. So we oftentimes assume things that don't work out in an actual randomized trial. Current is what matters. Current is definitely greater through the AP pad. That is what makes a difference. So for us, I think AP, as soon as you put on, is a way to go.
All right. That's what we've done as well. So it's reassuring to hear that's your methods as well.
The only last thing I'll say is about the issue in terms of logistics, right? The ERC says it's logistically very difficult to do DSED, to get 2 defibrillators on a scene. I'll tell you what paramedics hate. Paramedics hate people telling them what's logistically good or not. They hate that because we have services who've been doing this forever. And it's not logistically difficult. You get 2 defibrillators, whether it's a fire, whether it's an ambulance, whether it's an AED, we do it. How can you tell us something's logistically difficult, but ECMO is not?
Yeah.
Okay, so I would say 2 defibrillators on the scene is a lot easier than actually implementing a whole system of ECMO. Yet ECMO is a preferred modality. I think these are both great modalities. I think they should be treated in the same manner.
Okay, I was going to make my point after the mechanical CPR, but you've just brought up a perfect time for me to say this, which is what you've just identified is my major problem with AHA guidelines for resuscitation, which is they're trying to have a broad-based guideline that encompasses dermatologists in their office and like incredibly high efficiency resuscitation organizations. And I don't want a single guideline based on logistics. I want them to say, this is the best possible care. And then they could give a proviso and say, if your system is not capable of this level of logistics, it's okay not to do it. But to actually mitigate the right care, because it's not the easy care, is very problematical to me. And I think it makes for worse care for the high-performing organizations. So for both DSED and mechanical CPR, it's the same thing in my mind. It's it's logistically hard, or it costs some extra money. Okay, you could talk about that, but don't make recommendations based on that. And that's what I find they do time and time again and I almost think at this stage of the game, we just need a separate set of guidelines, which is they have ACLS and then they have ACLS for aggressive high performance organizations. And there's so much fodder that would fill that. Things like DSED would clearly be there. The physiologic monitoring of CPR with ART lines and other monitoring modalities, titrating vasopressor doses, predicate on that, ECMO, all of those things I think should be in a separate guideline than what you teach by rote to an internal medicine doc on the floor where no one else is coming to that code at some community hospital. They're not going to be doing art lines during arrest. So does that make sense, Shel?
Yeah. Scott, I could not agree with you more. I could not agree with you more. Stick to the science. Let the clinicians work about the logistic.
Yes.
You know what I mean? Clinicians are pretty smart at logistics, right? If there's something that's science-backed, they'll figure it out. So I completely agree with everything you said there. Completely agree.
For sure. All right, let's talk about some other medications. This was interesting to me. And for the most part, I think their guidelines were pretty much in keeping with my reading of the current literature. They've gotten rid of pretty much, I think, aggressively now, no empiric calcium, no empiric sodium bicarb, and no empiric magnesium, which is good because I still think there are people out there doing it. What's interesting to me, Shel, is